Good afternoon, everyone. Thank you for joining our June webinar, Information Blocking, 1 Year Later, Implications for Your Practice. Today, the webinar is presented by Cathy Bryant, TMLT Manager of Cyber Consulting Services, and I am Cassie Toerner, TMLT Manager of Risk Management. Before we get started, a few items that I would like to make note of. Downloads, we have quite a few resources available for you all today to download if you would like, as well as the PDF of the presentation. You can use that downloads file pod to the left of your screen. You can download all of those items there if you feel they would be beneficial, or just the ones that you're most interested in. Our presentation is being recorded today, and you will receive a recording link once we have completed the webinar. Also, at the end of the presentation, we will provide a link for the CME evaluation. Our team will process those in the next couple of weeks and provide your CME certificate to you. Just as a disclosure here, just take a moment to review this. It's just stating that Cathy and I have no financial relationships with any ineligible companies to disclose related to this talk. Also, this information is as is and is not a legal source. So today, our goals or objectives for this presentation are to discuss how information blocking applies to your medical practice, list steps you can take to assess your current practices, and improve compliance with information blocking regulations. So Cathy, can you set the stage for us and tell us a little bit about what information blocking is?
I'd be happy to, Cassie. First of all, thank you for joining us this afternoon. The background of information blocking is a little confusing to a lot of people. You may remember that information blocking had a delay in the actual start date due to the pandemic. But just to set the backdrop, information blocking is about access to electronic health information. And this is especially for patients. And this is very consistent with HIPAA. And I think you all probably may have heard other webinars where we have reviewed that HIPAA, or the Office for Civil Rights, continues to fine covered entities for failure to allow access to the protected health information. But information blocking actually takes it a step further, and we'll get into that in some upcoming slides. But as far as information blocking for you as a healthcare provider or practice, it is anything that the practice is doing that is unreasonable and likely to cause interference with access, exchange, or use of electronic information. This is part of a federal law. It goes all the way back to 2016 with the 21st Century Cures Act. The Office of National Coordinator was charged with the responsibility of developing the rules, and they took several years to develop the rules. They were actually first published in 2020. The rules are pretty straightforward about information contained within electronic health records that physicians must make available. Everything from discharge summaries, history and physicals, progress notes, consultant notes, imaging reports, laboratory reports, pathology reports, and procedure notes. There are some exceptions, and we aren't going to go in great detail into the exceptions, but that is something that you probably want to review at a subsequent date. Because as physicians or as medical practices, the physician has the discretion to determine the appropriate manner of sharing the information if they think that there could be potentially an issue. So, does information blocking apply to my practice? In a word, yes. The Office of National Coordinator took a very broad definition of healthcare provider, and it's actually outlined in a paper, a white paper that they produced, and it's the second downloadable file. But it basically is anyone who provides any kind of health care. So that is something that you're definitely going to probably want to make sure that you either know where this document is available or to download it and share with appropriate staff if they question how you are responsible for information blocking. But remember, it's anything that interferes with access or exchange of electronic health information.
So, Kathy, would a delay in fulfilling a request for access, exchange, or use of EHI, as you've been describing, be considered an interference under the information blocking regulation?
You know, every case is going to be a little bit different, and it's going to be looked at on a fact-based, case-by-case assessment. That's true within your practice. If you're looking at, would this potentially be information blocking, or certainly if there is a federal investigation for a complaint that you have failed to grant access under guilty of information blocking. That assessment would determine whether the interference is within the legally permissible access, exchange, or use of EHI, whether the actor, and oh, by the way, actor in this case is what physicians and healthcare practices are called in the rule. So if the actor engages in the practice with the requisite intent, and whether the practice has satisfied a condition of the exceptions, then this is unlikely that it would be interference. So if you think about it, if you have a patient portal, then the patient is requesting their lab results, and they can easily be pushed through the portal. A delay of an insignificant amount of time is not going to be a problem. However, if your staff does not respond to that for a week or two because the person that quote-unquote does that job is on vacation, that might be seen as a potential information blocking. Also, if the release of EHI is delayed due to some sort of state law, then it could be considered or not considered interference. An example that we came up with is if you have legacy software, a previous EHR that is not fully integrated with your current EHR, then, and you have to do some manual process of moving that information that's requested from the EHR into a form that you can upload to your portal, for instance. It's reasonable to think that that might take a short period of time, but because that's all electronic, long delays are not going to be accepted. But in some cases, a short delay would potentially be unlikely to be interference.
So Kathy, you are mentioning about pushing to the portal information. Tell us about an actor, which is a physician or healthcare entity, which you've mentioned, their responsibility to provide an individual's EHI on a physical media, such as a paper copy, a CD, or a USB drive. And also, can you touch on what fees could be charged if that's what they're requesting?
Sure. Sort of like HIPAA, under information blocking, or under the rule, the, the individual can request their EHI in a variety of physical media, whether that's I want it on paper, a CD, a USB drive. Um, those are all things that the patient has a right to ask for. In the definition of information blocking, any practice can actually charge for that type of media. But I would just remind you that the OCR is, from a HIPAA standpoint, has been very specific about how you can charge and what you can charge for for EHI, or in the case of HIPAA, EPHI, electronic protected health information. That you actually have limits on what you can charge, especially when the request is for the patient.
So on this slide, we just show you quickly the website of the ONC and how easy it is for a complaint to be made. It's very easy to Google, how can I make a complaint to the ONC? And you can see it's right there, very large in the middle of the page, report information blocking. You can quickly, or someone who has a complaint can quickly submit that complaint right there very easily. We just include that for your reference. I won't go into a lot of detail this slide here because it is available in the downloads as well. But just as Kathy mentioned, when a claim is made, it is on a case-by-case basis. The ONC could look into it and do fact-based investigation. It's solely based on an analyst inference from the facts and allegations that were presented by the claimant. And of note that the ONC can refer to the OIG if they feel that it is necessary. So we include this slide here just so you can take a look at claims that have trended, and you can see that healthcare providers are, by and large, that have the majority of the claims compared to other actors or industries that are out there. Also, you can see here of interest that the claims that are being submitted, or complaints rather, have gone up from the patient. You see that it trended down from attorneys to almost zero to now where patients are submitting more claims than the attorneys used to. So patients are aware that this is an option for them to submit these complaints, and you can see that by these numbers that that are showing now.
So we know that probably one of the most talked about parts of information blocking is patients having immediate access to electronic health information. And we understand that not all EHI is created equal. This is an opportunity, I think, for you to think about how your practice. If you are in a practice that routinely diagnoses something like cancer, and you are complying with the information blocking rule, you may want to have a conversation with the patient when you're ordering diagnostic tests to say, you know, if you want to see the results before you see me, they will be on your portal. However, if you don't want to know until we're sitting having a face-to-face conversation or a telemedicine visit to review your results, then don't look at the information. Of course, we also know that labs and imaging centers are also covered entities and actors under the information blocking rule. And those entities a patient can go to and ask for direct access to those records as well. So it's not only your releasing the records, it's also the potential labs or other diagnostic settings that could have to release the records to the patients. So, Cassie, are healthcare providers subject to information blocking regulations if they do not use any certified health IT?
Yeah, sure, Kathy. I wish I had a better answer, but yes, they are. Per the definition of 45 CFR 171 noted here, healthcare providers are responsible regardless of certification from the ONC. The information blocking rules will apply to that healthcare provider. And Kathy, would the prevention of harm exception, I know we mentioned exceptions briefly, and you were discussing laboratory here, a delay of release of laboratory or other test results, ordering physician can evaluate each result for potential risk associated with the release?
So, unfortunately, no. Again, this is probably one of the most talked about parts of information blocking when it comes to physician practices or physicians having discussions among themselves. There is no exception for blanket delays that affect a broad array of routine results, and you can't qualify that under the preventing harm exclusion or exception. So generally, when you order a test, it's in the context of your patient relationship. And the physician or clinician ordering the particular test is the one that really needs to have that communication that I was discussing earlier about if you don't want to know the results of the tests ahead of time, then don't look at the results. But we talked a little bit about exceptions, and we're not going to do a deep dive into the exceptions, but it is not information blocking if a physician practice or actor engages in the practices that are reasonable and necessary to prevent harm to a patient or another person, provided that certain conditions are met. And they're outlined here on this slide. Again, this is one of those white papers that's probably really good to have readily available, because if you have a patient that you are not going to provide the labs immediately for, maybe it's because you think there's a potential that if it were a teenager, that if their parents saw the results, that they might have either physical or mental harm caused to them. So there are reasons to not release the results directly, but you have to be very careful and make sure that you are really evaluating that on a case-by-case basis and not just waiting.
So Kathy, you mentioned a little bit here about the healthcare providers, and is it acceptable to establish a practice-wide policy that impose delays on the results of labs? As you've mentioned, lab results seem to be the most concerning of results. So is it acceptable for a physician to delay a release to inform the patient of the results?
Unfortunately, as we've said, this is likely to be seen as interference if it is a practice-wide policy because it's not taking the individual result and the individual uh, exceptions into account. And I think, there are things that we see all the time in medical practices. There may be signs in medical offices or even in exam rooms that say something like, lab work will be available in your portal 5 days after it's available to the physician for review. That's kind of a red flag saying the doctor gets to look first. That's kind of one of those blanket rules that is likely to be considered interference. So you might want to take a look around your practice and make sure that maybe those are not an issue uh, in your practice. So we're going to switch gears just a little bit and quickly cover like the 5 most common myths about information blocking. So the first one is, does information blocking prohibition apply only to patient requests? And the answer is no. It applies to any request for EHI from any requester. It is not limited to a patient request. And I think this even should make it easier for your practice once everyone is thinking about information blocking and the benefits of information blocking. So if you need to see lab results from another practice, or if there is a situation that someone calls you when a patient is in their office and they want to see their last EKG, information block, or the rule actually allows you to share that information and not just directly to the patient.
So another myth is information prohibition does not apply to outpatient providers. The rule is rather broad, that the definition that the ONC created, and it practically includes all healthcare providers. So that would include outpatient settings. So for those of you, I see some questions from hospital settings, yes, or in private practice, it would apply as well to any outpatient providers.
Oops. The next myth is health information management, or those of us that have been around a while might call it medical records, does not have a role to play in information blocking compliance. Well, if you're lucky enough to have HIM or medical records that handle the release of information in your practice, they are very much involved. This is something that they do on a daily basis, is handle the requests, and they will need to know the information blocking rule pretty much inside and out. Otherwise, it's going to be, if you don't have a whole department or a designated person, then you're going to have to educate a lot of people in that particular, in this particular rule.
So information blocking changes the timeliness requirement in HIPAA. No, it doesn't. The ONC does not give a rule here as far as a time frame for requirements for providing the EPHI. But you will want to keep in mind that you will want to have reasonable and timely access, as that is the expectation. I have heard some experts say that the best practices for PHI to be available at all times, because the ONC believes that data in many ways belongs to the patient. So that's just a general guideline, but again, they did not give a time frame there, but you would want to keep in mind the time frames that are state law here in Texas as well when you're looking at these requirements to provide records to the patient.
So the last myth is it information blocking if a provider charges fees for supplying copies of medical records? The ONC has stipulated that there are certain costs reasonable that can be incurred for access, exchange, and use of EHI. But again, this rule gets really intertwined very quickly with HIPAA and state laws. You know, the HIPAA requires that if you are going to charge for the electronic, or if you're going to charge for the records, there are reasonable fees that can be charged, and there are certain things that can be included or not included. One of which is like if you have paper records stored off-site and you have to pay an employee to drive across town, go through the boxes of records to retrieve the record and drive back to the office to scan it in. The retrieval of records is not allowed under HIPAA. It's a little gray, in my opinion, as to what the ONC says. So it's really going to be a matter of balancing both of these rules. But if something is readily available and can simply be pushed out to the portal, then charging a fee is not going to be acceptable. So one of the things that we wanted to really stress is that we feel like it's very important that you really take a look at your practice. Review your current processes and written policies and procedures. The polling question that we had going in the beginning that asked, how have you incorporated information blocking? Have you created a separate policy? Have you incorporated it into other existing policies? Or have you actually started or haven't started incorporating it at all? And about 40% of you said that you had incorporated it into other existing policies. And the other 60% basically said it had not been started. So with the information today, with the much more detailed information that's available in the downloads, those are all great places to start. I would certainly encourage you to use the ONC Office for National Coordinator website. They have a vast amount of information available on that as well. So just to get you started, we started a short checklist as a starting point. Do you have a written policy and procedure that addresses information blocking? How do you address access to diagnostic tests as soon as they become available to you or your practice? How do you audit the release of records? And this is just in general, to make sure that compliance is not an issue. Have you educated your workforce on information blocking and what they should do if they receive a complaint claiming information blocking? And what is the process for receiving, investigating, and resolving those complaints? And After you've done your review, and you can certainly add additional questions to this, be sure and document it so that if any question ever comes up as to compliance, you can say, on this date, we did this.
So a few additional takeaways about information blocking. Currently, there are no financial penalties for providers who do not meet the rule, so that's somewhat reassuring. We recommend educate your staff who receive requests for information to release medical records. Have a plan for how to handle requests for information and connecting to apps. As Cathy has mentioned, having written policy and procedure on how you handle records release and even fees for charging for medical records, I would add there too. Discuss access with your patients when diagnostic tests are being ordered, and periodically assess compliance with your policies and procedures to ensure that they are current. So with that, we will move to some Q&A. And before we do that, we would like to say thank you for joining us today. We will launch the CME eval into your browser. Again, our team will process that and get you your CME certificate within the upcoming weeks. As a note, for July the 26th, we do have attorney Karen Zahner with us, and the topic will be responding to negative responses on social media can be costly. So we look forward to you joining us then for that topic. Again, the downloads are available for you if you would like. So if you have a question, we're going to go through a few here. I think some of these have been answered, but Cathy, first question is, when a physician office or hospital call asking for the last note, EKG, most recent records for appointment or surgery, do we still need to ask them to send a request? I'm guessing for an authorization. Sometimes it feels like we're waiting for those. It's time consuming. Can we just go ahead and send it without our authorization or a request?
So both under HIPAA and to be compliant with information blocking, those can be sent without a patient authorization because those are for continued care or treatment, and that has long been allowed under HIPAA. But certainly it's reinforced under this information blocking rule, because remember that the information blocking rule said it's not only the patient but other requesters that the rule applies to.
Great. Cathy, you touched on this a little bit, but maybe expound slightly on fees that can be allowed by the Texas Medical Board for release of medical records.
So we have some great resources on the TMLT website, and we also have previous recorded webinars that are available that talk about fees. There is a difference in charging the individual or the patient for access to their medical records under federal law than if it was just someone, maybe an attorney, an insurance company, some other third party. There are distinctly different fees. So if you need to, if you want links to those, or if you have greater questions, you can always email us at consulting@tmlt.org and we can get back with you individually. But in general, the answer is you can charge the fees allowed by the Texas Medical Board for requests, but not to the individual. I would err on the side of caution and follow the federal rules that are outlined for individual requests for medical records.
So for physicians that practice in multiple settings, such as office or skilled nursing or acute care, do they get a notification of a complaint and which location it arose?
You know, we haven't had a whole lot of transparency from the ONC about their investigative process. There is a little more detail on their website, but in any everything that I have read, I have always been under the impression that you would know details if the complaint was against you, that as part of their investigation they're going to have to provide you with enough information about the situation so that you can hopefully help them clarify that this was not information blocking.
So what if there is a problem with a verbally abusive patient that has been terminated from the practice and the document that exchange has been documented, the patient told us in the chart? Can that be problematic if the records are released to the patient themselves?
I don't think there's any exception for releasing records to someone that you've fired from the practice, regardless of the reason that you fired or terminated them as a patient. I think you would stand to be potentially in a worse situation if a patient turned around and reported you to the Office of National Coordinator for Information Blocking, reported you to HIPAA, or refusal to release medical records, or even the Texas Medical Board for refusal to release medical records. You could be facing multiple investigations at one time.
Perfect, Kathy. So we have a question about labs with significant findings, which will require some explanation. The patient has an appointment next week. Can I wait for that appointment to inform the patient, or should, I'm adding to this question, should the information go ahead and be put out in the portal, Kathy, as for information blocking rule?
As far as the rule goes, the results are supposed to be available to the patient as soon as they are available to the ordering clinician. I believe is the exact, or close to the exact wording in the rule. So that means you technically cannot wait unless you believe that one of the exceptions, such as potential harm to the patient, could be exercised. Of course, again, this is the one that you want to perhaps have the conversation at the time you order the significant lab and say, it's going to be available, but you don't have to review it if you don't want to.
Great. Kathy, the physicians who are not enrolled in any government incentive for use of EHRs, are they held to the same rules for information blocking?
I do not know of any exception for physicians who are not enrolled in the EHR benefit because it applies very broadly to providers, and it does not have anything to do with payment or incentives.
Great. So we mentioned the portal. A question here is about patients who request email for their lab results. What is the appropriate response for a request for email?
We get this question a lot. We actually, a couple of months ago, had an attorney speak about the problem with emails as far as breaches go that you might want to go back and take a look at. But a patient has a right to request information or their records in the form and format that they desire. This is true for both information blocking rule and for HIPAA. And if someone says that they want to have their records emailed and you do not have a secure way to email them, meaning you don't have encrypted email. As long as you explain to the patient that you are going to send, or they would be in an unsecure manner, and the patient agrees, you can send them. From a risk management standpoint, we always encourage you to make a note that you've had that discussion with the patient, and the patient insists that they want them sent in an unencrypted manner.
So for the portals, is it recommended to add a statement, something to the effect of, please note your physician may not have reviewed X test result. These results need to be evaluated by your provider before action is taken. Is that something that would be recommended or helpful for portal use?
I've not seen that, but that might be something to consider uh, when you're actually, you know, uh, posting labs. I don't know how easy that would be done. You might have to work with your EHR vendor or to see if you can like put that statement on all the results. But that's an interesting idea to explore.
If another office requests information and we do not have a signed release, how do we know the patient is actually a shared patient?
You can always, if you question it, if they've never said, Dr. XYZ is my primary care physician or my specialist, you can always err on the side of caution and either send the patient a message through the portal or pick up the phone and call them and say, hi, we've had a request from a certain practice, and I just wanted to know if you are seeing that physician. Some of it is a little bit of trust when it comes to physician, physician offices requesting records.
So the next question is, how does one best manage documentation of patients behaving inappropriately? Example being rude, violent, non-compliant, when it can be expected that the patient reviewing such documentation will further be exacerbated. And I've actually seen, Kathy, some words and on just doing regular Google searches of words to avoid, knowing that the patient will have direct access to this information that's being documented. So that might be another topic in the future of tips for documenting to avoid some of these words that may be deemed inflammatory or cause further exacerbation. But I'll let you elaborate on that one.
Well, I think certainly this is probably a question that our risk management department gets probably more frequently than we do from a more of a compliance standpoint. I think you have to just use good judgment. I think in any records now, you have to assume that the patient is going to read those, because patients are being more and more encouraged to access their records and be a part of their healthcare decisions. So I would just exercise good caution and not use those inflammatory words that Kassie was talking about. And if you're ever uncertain if you should phrase it that way, you probably shouldn't.
So next question, are the physicians required to provide portal to their patient for access if they're using an EHR that has it?
I don't think there's any requirement for it unless it's part of some of the incentive programs, and I won't go into that today, but it's an easy way to get patient information without, and a secure way, without having to worry about encrypted email, um, and it's a very common way that patients want communications these days.
So maybe a little bit of a question here that has a lot of variables that would go into it. If your EHR portal goes down due to no fault of your own, um, would this be an infeasibility exception, potentially?
Actually, there is a frequently asked question on the ONC website that talks about if your system is down, not just your portal, but it could be your whole EHR is down uh, because they're doing maintenance or something like that, or you're doing an upgrade. Just be sure and document that, on Tuesday the 28th, the portal was down for some reason for this period of time, and that's going to certainly be an adequate defense if you ever were accused of information blocking.
One final question here that I'm seeing, Kathy, is again related to fees, which you've mentioned to reach out if you have any questions about fees, because we do have numerous resources on fees for copying. But this one is referring to if a patient is fired from or terminated from the practice, can the fee be charged to the patient even if they've been terminated?
If you charge the fees, I think within reason, you're certainly always, that's always a possibility for you. However, if you already think you've already got an unhappy patient, is this going to be one more thing that's going to make them more unhappy? And would it be better to simply not charge them the fee um, in hopes of kind of closing that chapter with that patient without having to, put more reason for them to be concerned or upset with you and potentially file complaints elsewhere?
Great. And I think, Kathy, this goes in line, a follow-up question. Is it safest option to forego a fee when releasing directly to a patient if there is some issue as we've been discussing?
I think that's a fairly sound advice. Um, again, you don't want to inflame the situation any more than you have to, if that's a possibility. Um, so to just take a step back and even if they're requesting it on a thumb drive or a CD, or even if they're asking for 500 pages to be printed out, it seems to me that that is something to consider in the big picture rather than wait until the patient really gets mad and starts filing complaints.
Okay, I will give a couple of seconds here if there are any other questions. That looks like the end of our question list. We do appreciate those of you who have asked a question thus far. Again, the downloads are available for you of all of the resources that we've mentioned thus far. And as Kathy mentioned, if you have a specific question, particularly in regards to fees, because that seems to have been a common question, please feel free to reach out to us at the consulting@tmlt.org email, and we'll be happy to share with you the resources that we have. We know that fees can be a little bit tricky in different scenarios as it relates to release to a third party versus the individual, and whether it's an electronic portal format or a CD or a paper copy, as we've mentioned. Okay, I'm not seeing any more questions, Kathy, so we will go ahead and launch the CME eval in your browser. That should pop up for you to take a peek at and submit if you're looking to get CME for this presentation today. Kathy, any other final thoughts?
I I know that this is a challenging topic, and if you have questions, we're more than happy to try to help research those. Again, the Office of National Coordinator website, if you just Google ONC information blocking, you're going to find tons and tons of resources, including webinars that were actually produced, most of them last year, on by the ONC staff. So there are lots of good resources out there, but we're more than happy to help out. And I just echo Cassie's appreciation for you giving up some time today to join us. And we hope to see you next month when Karen Zahner joins us as well.